expanded, so it's dealing with multiple different issues. There's going to be some issues in terms of airway management, ventilatory management, including what to do with alarms, and then hemodynamic management of shock, as well as the approach to a septic patient overall, which encompasses all of those things. So again, Adel, just give me the thumbs up if you hear me well. Okay, perfect. So, and I get multiple thumbs up. Great, thanks. Let me see, how many do I get up to now? 46 so far, so that's close enough. So what we're going to do is we're going to try to, everyone should try to put themselves in the mindset of, you know, it's 1 or 2 months from now, and that you're the R1 resident on a clinical service in the hospital, and the nurses are concerned, and you're the one who's called to first assess this patient at the bedside. And so we'll try to make it as clinically relevant as possible while using the fundamentals that are in the lectures in terms of acid-base, approach to shock, acute respiratory failure, and ventilatory management primarily, although some other chapters will be important as well. Okay, so really the major goal is to get the approach to assessment and stabilization of the patient with sepsis. And when you're talking about critically ill patients who become critically ill while they're in hospital, I think sepsis would probably be the #1 cause that would lead someone on the floor to deteriorate and need to be transferred to an intensive care unit. So it's probably the most important topic for you to know in terms of the day-to-day management on a ward. So the goals of this session are to recognize early sepsis, describe the steps needed to manage an acutely ill patient, particularly one who's septic, and stabilize the septic patient. We'll talk about the clinical parameters, the historical information, the physical exam information, and the laboratory information that you need, the database that you need to collect, how to interpret that database, and how to communicate that well to other people. While you're doing the thing about people who are acutely critically ill, you're simultaneously collecting the database and intervening at the same time. And while you're using the response to those interventions with your reassessment to give you a better idea what's going on. So it's a continuous process. They use the direct mnemonic here, but the idea is that you're simultaneously collecting information and intervening at the same time. It's not a classic internal medicine situation where you do the history, then you do the physical exam, then you do some lab tests, you create a differential diagnosis, and then you move, you do some more testing to narrow the differential diagnosis, and then once you have your final diagnosis, then you come up with a therapeutic plan. In this situation, you have somebody who it could be potentially acutely physiologically unstable, so you don't have the luxury of time to go through that entire process. You have to simultaneously start treating while you're doing the rest of the workup. And one of the basic rules is it's not necessarily necessary to make a diagnosis before you start acting. So you're not trying to make a firm diagnosis, you're trying to recognize acute airway compromise and acting, acute respiratory failure and acting, shock and acting. Again, we'll talk about the basic ventilatory management and the basic hemodynamic management. So the case scenario, so everyone can follow along. I'm just going to see how many people are up here now, 51. So it's a 74-year-old woman who's on the general surgical floor, and she's noted to be confused and tachypnic. She's on post-operative day 4 following a cholecystectomy. So first of all, you have to wonder why she's still in hospital 4 days after a cholecystectomy. It doesn't give you a lot more information right now, but you would expect, if that's the case, that either she had some comorbidity ahead of time or she had some sort of complication post-operatively. But anyway, we're day 4 and she's in the hospital. She looks like she is morbidly obese with a height of 5.2 and a weight of 170. Again, we don't have a lot more information, but certainly that's one of the key rules of managing somebody who's acutely unstable. The database is continuously evolving, which is why you have to develop a process in your mind where you're continually reassessing the situation, because the database is always going to be a fluid sort of situation with minimal data at the beginning and hopefully more and more as time develops. So on exam, she's confused. So that's concerning. She's moaning, but she doesn't have any sort of specific complaints. Her mucous membranes are dry, and you'd have to wonder why there's signs of volume depletion or dehydration, considering that she's been in hospital for 4 days, but they're described as dry. And then on physical exam, she has obvious rales and rhonchi at the right lung. Her abdomen, so the abdominal exam, of course, would be of significant interest here because she's just had a lap chole. Was it a lap chole? It just says cholecystectomy. So she just had a cholecystectomy. I'll assume it's a lap chole. But certainly when you're approaching a patient like this who's in distress, you're trying to get a mental image of what the patient could potentially have, which is why the comorbidity is so important. But also considering that she just had a cholecystectomy, there's a whole series of complications that could occur that you're going to be looking for, right? So what could the complications be from a lap chole? Well, sepsis, an intra-abdominal sepsis is certainly high on the list there. But other possibilities would be, she's morbidly obese, she's 74 years old, and she may have significant comorbidity. She could have a post-operative MI, right? Pulmonary embolism would be something else that you'd be thinking about. Or she could have gotten an infection somewhere else, whether it's her lungs, whether it's a urine, whether it's the abdomen, or a skin and soft tissue infection. So those are the thoughts that are going through your mind at this point in time. The abdomen is soft, so it doesn't look like that's the source. And the wound, the post-operative wound, is clean, so it doesn't look like it's a wound infection at this point in time. Again, limited information. What we do have is a set of vital signs. The blood pressure is 100/40. Now, that's a little bit on the low side. You would be interested in going back in her chart and find out what her baseline blood pressure was before the operation, and particularly in the last few days. She might be somebody who chronically has a fairly low systolic blood pressure, but more than likely a 74-year-old female is going to have a blood pressure of 120, 130, or even be hypertensive beforehand. So that drop in that systolic blood pressure would be concerning, as would be the mean arterial pressure of 60. And then when you look at her heart rate, she's got a tachycardia. It doesn't tell you what the rhythm is at this point in time, but that heart rate would be a sign of concern. Even more concerning would be the respiratory rate of 33. So one of the things this course emphasizes is that of all the vital signs, the respiratory rate is often the first early warning sign that something is brewing somewhere. So somebody who is tachypnic, you have to look at very carefully, and you have to look and try to determine what the cause of that tachypnea is often the first sign of a critical illness itself. And then she's febrile at 39.4, and she's got an oxygen saturation of 88% on room air. So to summarize it at this point in time in your mind, you have a elderly woman who's morbidly obese, who's still in hospital 4 days after a cholecystectomy. And now you're being called to assess her. And the concerning things is that she has altered mental status. which again has to be explained in some way. She is at risk for a stroke as well, but again, this sounds more like this is encephalopathy. She has hypoxemic respiratory failure associated with localized findings on the right lung. So that it gives you an idea about what the cause of the hypoxemic respiratory failure could be. And she is likely in shock as well, with a heart rate of 120 and a low blood pressure. So this woman, you should have significant concerns for. She's certainly somebody who may deteriorate fairly rapidly, fairly soon. So that's the detection part of the exam right now, and we'll stop there. Obviously, we don't have all the information that we need, but you're going to have to intervene first before you go on and collect more information. So that's the whole idea of the primary survey intervention, then the secondary survey, and then maybe the tertiary survey or the continuous reassessments. So what do we need to do? Well, okay, you can just take an ABC approach to her. The airway seems to be intact. There's no information that tells you that she's obstructing the airway or she has some upper airway difficulty. So you don't have to worry about that. But in terms of going on to breathing, she's tachypnic at 33, and more importantly, she's saturating 88% on room air. So the first response would be to give her supplemental oxygen. And that could be just with nasal cannula. That may be enough at this point in time, but you probably just put a face mask on and hopefully measure the saturation continuously with a pulse oximeter. You're going to establish, then moving on to circulation at this point in time, you're going to establish appropriate IV access. So checking the patient and determining what IV access the patient has already and making sure that that is adequate is going to be key at this point in time. And then most likely, again, you have to make a determination about whether you think this patient is in pulmonary edema or not. The auscultation would seem to indicate that there's a localized process as opposed to a diffuse process. But in the absence of significant pulmonary edema with a heart rate of 120 and a borderline blood pressure, more likely than not, you're going to give the patient a fluid bolus to help with the hemodynamic aspect. As far as the mental, moving on to D, a quick neurologic exam just to make sure that she's got no focality in terms of her motor exam is probably all you're going to do at this point in time. Remember, anytime somebody has altered mental status, you're going to be checking to make sure the brain is adequately perfused and there's adequate oxygenation. There should be enough brain perfusion with the vital signs we have right now. But the brain needs not just perfusion and oxygen, it needs glucose. We don't have enough of a history about this woman, but a morbidly obese 74-year-old female is commonly diabetic. And whether she's diabetic or not, more so if she's diabetic, but whether she's diabetic or not, we need to do a chem strip to verify her glucose right now, right? So that's basically where you're at. Now you have to decide what blood tests, or what tests, I should say, you're going to need to do to further determine the severity of her physiologic derangement and to better lead you to the correct diagnosis. So in terms of the testing that you're going to do, you start with the blood tests, and you're going to repeat everything at this point in time. You're going to do a CBC. Again, what you'd be looking for there, she's post-operatively, so she might have an intra-abdominal bleed, for instance, or she could be developing a concealed GI bleed because of stress ulcers or anything like that. So the hemoglobin level will be important, and you'll be comparing it to the previous one. You're going to be looking at the white count because, again, sepsis or infection is high on your list at this point in time. And there's lots of reasons why patients will develop a coagulopathy or thrombocytopenia. So the platelet count is going to be important as well. You could again, you more likely than not will do an INR PT-PTT on this woman, looking for coagulopathies itself. In addition to that, you're going to do a Chem7, looking for electrolyte abnormalities. She already has some evidence of the brain, the lungs, and the circulation system being affected. So you'd be interested in whether the kidneys are also having acute injury. So the creatinine will be important from that point of view. And the Chem7 will also give you some information on the acid-base status of the patient itself. Arterial blood gas will give you a better information in terms of the acid-base status. It will give you some information in terms of the respiratory status of the patient, whether it's hypoxic or hypercapnic respiratory failure. And you'll get a lactic acid on that as well, which will again be a warning sign that the patient may have significant sepsis. The other things that you would do, again, in this patient, because she's post-cholecystectomy, you'd be interested in her bilirubin, her alkaline phosphatase, and her liver function tests. In addition to that, she needs an EKG and a troponin. She's at risk for a perioperative MI, even if it's not the primary process here. It certainly could be a secondary process because of the stress of sepsis. And she needs a chest x-ray at this time. So that's where we are at this point, and that's sort of the initial response. So you've done your initial response, you've made your initial interventions, putting the patient on oxygen, giving a fluid bolus, and you're continuing to collect more data. And now it's 30 minutes later and you're reassessing the patient. And the vital signs at this point in time, well, when you do the reassessment, first thing is she's more confused. So that's not a good thing. It's not a sign that she's improving over time, at least from a mental status point of view. Her vital signs are pretty much the same as before in terms of heart rate and blood pressure and respiratory rate. You've now got her oxygen saturation up to 90%, which is, still very concerning. It's on 4 liters on nasal cannula. You're now starting to get your labs back, and you notice a sodium of 149. Now, that would suggest that she has some dehydration. The other possibility of that is she got a large volume of sodium for some reason the last few days, whether she got a lot of sodium bicarb or hypertonic saline. That's unlikely to have happened right now. So that sodium of 149 may be one of the reasons why her mental status is off as much as it is. Her bicarb is down to 18, suggesting that she has a metabolic acidosis. The American units here. The BUN that's elevated again would be suggestive of volume depletion, and she does have an elevated creatinine, so she does have an acute kidney injury. So you found yet another organ that is now dysfunctional in this patient. So she's clearly got multi-organ dysfunction, and you're getting more and more concerned. Her white blood cell count is up to 16,000, and it's got a left shift, so again pointing to infection. Hemoglobin is reassuring at 13 or 130 in our units. So we're not too concerned about a massive blood loss and hypovolemia as the cause of her shock at this time. The platelets and bilirubin are not really going to be major determinants at this point in time in terms of what you're going to do. You also have a blood gas back at this time, and it's pH is 7.3. So she's clearly acidemic, and you look at her PCO2, it's slightly low. So she has a respiratory alkalosis, but what's concerning here is it's not lower, right? She should be able to compensate more than she's compensating right now from a respiratory standpoint. So it indicates to me that she is limited in terms of the amount of respiratory compensation that she can have. The bicarb of 19, we've talked about in terms of there being a metabolic acidosis. Her PO2 is only 60 with a saturation of 88% on room air, again, hypoxemic respiratory failure. And she has this elevated lactate at 4.2. Now, the course says that the reason why lactic acid is elevated is because of inadequate oxygen delivery in a sort of a global tissue hypoxia, and therefore the switch from aerobic to anaerobic metabolism. And that's sort of the traditional teaching. I'll just tell you that that is being questioned now in terms of the mechanism for lactic acidosis and sepsis. There are probably other metabolic mechanisms that are more important. But it is clear that if your lactate is elevated at 4.2, above 4 for certain, it should be again, another early warning sign for people that this is a patient who is very sick and could deteriorate very rapidly. So then you can go on and look at the chest x-ray. Maybe I'll just, no, I'm not going to bother. So hopefully you all have the diagram. If you don't, the chest x-ray just shows a clear infiltrate in the right mid lung zone. So a significant right middle lobe pneumonia. And that's why you're hearing what you're hearing. That's why the patient has hypoxemic respiratory failure. So then in terms of your reassessment, you can now say that you have a 72-year-old morbidly obese female who's 4 days post cholecystectomy, who's presenting with altered mental status, hypoxemic respiratory failure, borderline hemodynamic shock, and acute kidney injury, most likely secondary to pneumosepsis or pneumonia with sepsis and hyperperfusion. Okay, and that would be, if you're able to communicate that over the phone to somebody, it gives somebody a mental image and a mental picture right away. And you can describe, it's clear that this patient needs aggressive attention fairly quickly. And it's also pretty clear that this patient needs to go to the intensive care unit pretty quickly. So then it asks you how to define sepsis and septic shock. You know, there are multiple definitions in the literature, and there is the Surviving Sepsis campaign keeps trying to define them more and more. The basic premise is that sepsis is life-threatening organ dysfunction that is caused by a dysregulated host response to infection. So it's the host response to the infection leads to end organ dysfunction. And you can quantify that with a SOFA score. Again, the SOFA score, you look at the criteria, the respiratory rate is, again, one of the key criteria, and one, again, I'd point out is the early warning sign. A change in mental status and a systolic blood pressure less than 100. So this woman has 2 of the SOFA criteria. Probably you could say you can give her the point for the third one. Septic shock refers to, so you can have sepsis-associated hypotension. So that means the blood pressure drops down below, but if they're fluid responsive, they don't meet the criteria for septic shock. They, in order to meet the criteria for septic shock, you have to have an adequate fluid challenge, which is usually classified or defined as 30 mLs per kilogram of crystalloid. So an adequate fluid challenge, but without a clear response, and a need for vasopressors. Okay, so this patient hasn't quite met the criteria for septic shock yet, but certainly you're worried that she may proceed to that direction. Once you get up to the point of septic shock, your mortality is somewhere between 30 to 50%. So in terms of, trying to risk stratify this patient, you can say that for every organ dysfunction, your mortality goes up by about 10%. She's got 1, 2, 3, 4 system failure, so you're putting her about 40% mortality based on that. And then borderline hemodynamics, if she starts going into septic shock, you're talking about 50% mortality. So you get an idea of just how sick this patient is. All right, so then we're moving onward and we're assessing her again. She's still confused. Yeah, her blood pressure has dropped to 90/50 right now. Her mean arterial pressure is 58. I prefer to look at the mean arterial pressures than the systolic and diastolics for the most part, because that's the pressure that's most relevant for end organ perfusion, and that's what we're most concerned about usually. She's still tachycardic at 120. She's still tachypnic, and she still has the borderline oxygen saturation and the temperature. So then the next question is, what needs to be done next in the management of this patient? So really, at this point, she needs to be transferred to the intensive care unit and for a higher degree of monitoring. So what would we do down there? She gets to the intensive care unit, again, going ABCs. The airway is not a major concern at this point in time. In terms of oxygenation and her increased work of breathing, we might consider starting her on Optiflow at this point in time, maybe even BiPAP, but BiPAP as would only be a temporizing maneuver here because we think that she's got a pneumonia. If she's got a pneumonia with a lot of secretions, the BiPAP will actually eventually worsen that. But probably we'd put her on Optiflow initially. And then again, we would try to make some determination of volume status, looking at her JVP, or putting in a central line and looking at her CVP, or taking a ultrasound machine and looking at the IVC to determine whether we think that she's relatively hypovolemic and whether she would respond to fluids. So if we think that's the case, then we would give her another fluid challenge. Remember, the only reason that you ever give somebody a fluid bolus is because you're thinking that the patient is so-called volume responsive, meaning that by giving them fluid, you're going to increase venous return, which is going to lead to an increase in stroke volume, which causes an increase in cardiac output and an increase in perfusion. That's why you give fluids. If you're up to the flat portion of the Starling curve, then giving fluids is not going to have any beneficial effect and will only start causing problems at that time. But again, early on, that's really more considerations for the fine tuning of the resuscitation that we do in the intensive care unit. For the floors, for the most part, you're going to give the patient fluids unless you think that the patient has significant pulmonary edema and giving fluids is going to worsen itself. So the patient is put on Optiflow. We're checking the IV access. We're giving a fluid bolus. She's on a cardiac monitor. She's on a non-invasive blood pressure monitor. We will likely put in an arterial line to allow us to get minute to minute or second to second monitoring of the blood pressure, and also to do more frequent blood tests itself. We'd likely put in a central line, and the central line will be doing two things, or three things actually. The first thing will be measuring a CVP. Actually, the first thing will be when we put the central line in, it's put in a sterile fashion. So I didn't mention the blood cultures and the pan cultures that we need to do for this patient. When you put in a line in a sterile fashion, like a central line, it's an ideal time to draw blood cultures through that line. And then beyond that, we would also measure a central venous oxygen saturation. And the reason why we're doing that is we're looking to see, or we're trying to determine whether the cardiac output or the oxygen delivery is adequate for the patient itself. If the central venous saturation is less than 70%, we would take that as a sign that the patient has global tissue hypoxia or not enough oxygen is being delivered to the periphery. Remember that the three determinants of oxygen delivery are cardiac output, hemoglobin level, and oxygen saturation. So if the central venous saturation is low, that means more blood has been extracted from the peripheral tissues because the oxygen delivery is inadequate, and therefore the blood coming back to the heart is going to be much more desaturated than it normally is. Okay, so let me see. We got the Optiflow on, we got the IVs going, we got the fluid going, cardiac monitor, NIBP, arterial line, central line placed in, and we're elevating the head of the bed to help with the respiratory status. The other thing I didn't mention early on would be, and this should have been done on the floor, we have good data that once a patient becomes hypotensive secondary to sepsis or infection, the time to get to them getting the antibiotics is very important. So for every hour delay that there is before the patient gets the appropriate antibiotic, mortality goes up by about 5 to 6% per hour. So when you think about that, there's not many things in medicine that are that time dependent. That's even more time dependent than going to the cath lab for a STEMI or going to the interventional radiology for a code stroke, for instance. So given the antibiotics should be given as quickly as possible. So we'll talk about the antibiotics here. What antibiotics would you give to this patient who is 4 days in hospital, who likely has pneumosepsis? On the other hand, you don't have all the information yet. You haven't ruled out the fact that she might have a urinary tract infection. And the abdomen seems fairly benign, but you haven't ruled out that this patient doesn't have an intra-abdominal sepsis. So if we're looking just at pneumonia to start off with, then you always break it up of whether it's a community-acquired pneumonia or a hospital-acquired pneumonia. And the choice of antibiotics are going to be different based on that, because the bugs that are affected, that cause the pneumonia, are different in the two situations. So classically, community-acquired pneumonia, it's pneumococcus that you want to really target, plus atypicals like chlamydia, mycoplasma, legionella. For hospital-acquired pneumonia or hospital-acquired infections, then gram-negatives become significantly more likely. And you always have to be considering Pseudomonas, which is or other multi-drug resistant type infections. So in this case, the go-to drug at the MUHC is Piptazo, and that's a broad spectrum antibiotic that's going to give you good gram-positive coverage. It's not going to cover MRSA, but otherwise good gram-positive coverage is going to cover most gram-negatives, including Pseudomonas, and it's also going to give you some atypical and anaerobic coverage as well. So Piptazo, and that Piptazo should have been into the patient before they arrived in the ICU. In other words, sometimes there's delays in getting the antibiotics up to the ward. There's all these logistical hurdles that sometimes occur in order getting antibiotics in. But you could make a strong argument that this Piptazo should be given IV push. And there are some places that tend to do that. We don't do that at the MUHC that often, but you can make an argument that it's so critical, the timing of the antibiotics to do an IV push. Now, if we thought that she had an MRSA for some reason, maybe she was MRSA positive from a previous admission, or she somehow acquired the MRSA in this hospital, we already knew about that result, then we would put her on vancomycin as well. So Piptazo, Vanco. It's very unlikely that this woman has a fungal infection at this point in time, so I wouldn't worry about that. You have to think about it at least. And other unusual infections are unlikely. But a proper antibiotic therapy is going to be key. Okay, so we're doing the direct methodology. We're coming back and checking every 15 minutes, 30 minutes, 1 hour, 2 hours, depending on how the situation is evolving. We're looking for the appropriate responses to our therapy all along. So now we're 2 hours later, and she's received 1.5 liters of crystalloid. She's gotten her IV antibiotics. She's still confused, and she's becoming lethargic, and her breathing is becoming more labored. And she states that she feels she is dying. Unfortunately, I've seen many patients who have said that to me, and they've been right. So I would take that. I would take that very seriously. So now we're looking at her vital signs. Her blood pressure is down to 85/40. Her MAP is 55. Her heart rate is 123. It's a sinus tachycardia. So you have an EKG at this point in time, and it's not shown, but the EKG shows just a sinus tachycardia. There's no other arrhythmia, and there's no evidence for an acute ischemic event right now, and I guess no signs of PE either on the EKG. Heart rate, you have 123. The respiratory rate's up to 45. The O2 saturating is 91%. They only have her on 6 liters nasal cannula. I think we would have her at least on Optiflow by this point in time. Still very febrile, almost 40 degrees. Her central venous oxygen saturation is 46%. Again, normal, again, is 70%. Her CVP is low at 2, and she has a lactate of 4.2. So again, to summarize, 72-year-old woman, morbidly obese, 4 days post cholecystectomy, who has pneumosepsis with multisystem organ failure, including an encephalopathy, hypoxemic and hypercapnic respiratory failure, a shock, and we can decide what type of shock this is in a minute, an acute kidney injury. So very critically ill. So they're pointing out, or they're pushing you to intubation at this point in time. And it clearly, this patient needs to be intubated. And the old way of saying A, B, C, you know, we think about intubation before the other things, but in real life, you do multiple things at the same time. And you could argue that this woman is going to be a very high risk intubation for multiple reasons. You know, she's 5'2" and she's morbidly obese. We don't have information to tell me what an airway assessment to tell me that she's a potentially difficult intubation, a difficult laryngoscopy. And we talk about difficult intubations, that's what people commonly think about, the act of being able to see the vocal cords with a laryngoscope. And certainly someone like this may be difficult from that point of view. You'd have to do a careful assessment. But more importantly, she's going to be a very physiologically challenging intubation because she's extremely hypoxemic right now. She's already acidotic, and she's got significant evidence of shock right now. So I would tend to try to resuscitate her a little bit better hemodynamically before I tried to intubate her, because there would be a high chance that she would go into a PEA arrest with these type of hemodynamics. With the active intubation, giving the medications that you're given, yes, there's you can make choices of medication to decrease the chance of a PEA arrest or a severe shock with the intubation. But she needs to be resuscitated a little bit better. So again, I would make sure she's on Optiflow. I might even put her on BiPAP at this point in time, as not to delay the intubation for a long period of time, but to try to pre-oxygenate her as much as possible and buy me 5 to 10 minutes before I put the tube in. More importantly, we have to look at her hemodynamics. And so we have to try to determine what type of shock she's in. So remember the lecture you talked about the 4 classes of shock. You have hypovolemic shock, you have cardiogenic shock, you have obstructive shock, and you have distributive shock, right? And she's a septic patient, so most people would be thinking that this is primarily distributive shock. And there certainly probably is a major component of that. Obstructive shock is unlikely in this woman. You have to think about it all the time, but her JVP or CVP is not elevated. You would expect an elevated CVP if this is a tension pneumothorax. You'd expect an elevated CVP if this is cardiac tamponade. So it's unlikely. You can at least eliminate obstructive shock from here. In terms of there being a hypovolemic component, with a CVP of 2, she is still relatively hypovolemic. And again, if we intubate her and put her on positive pressure ventilation, there's a good chance we will drop venous return further and drop her cardiac output further. Is her cardiac output already compromised? You'd have to say yes, because 1, she's got a lactate level of 4.2, but more specifically, her central venous saturation is 46%. And if the central venous saturation is 46%, O2 delivery is not decreased because of a hemoglobin. The hemoglobin is 130, and the O2 saturation 90% is not that bad. So it means that the cardiac output also has to be decreased in this woman. And she could have a sepsis-associated cardiomyopathy. Again, she may be having an MI that we're missing right now, or we don't have that much her previous history. Why is she in hospital for 4 days? That's what I keep asking myself. Maybe she had a significant ischemic cardiomyopathy before she came into the hospital, and her baseline ejection fraction is only 25 or 30%. So those are the type of things I'd be going through my mind. I would be trying to aggressively resuscitate her from a oxygenation standpoint and a hemodynamic standpoint before I tried to intubate her. So with a CVP of 2, I would have fluid running again. She's already had 1.5 liters of crystalloid, but I have another liter of Ringer's lactate going wide open as fast as possible with a pressure bag in place. And I would start her on Levophed right now to raise her blood pressure up to a reasonable level. You'd like at least around 110, 120 systolic before I decided to start to intubate her. So, and again, oxygenation, we talked about this the last few days. You know, what you'd like is to be able to pre-oxygenate somebody so you had 8 to 10 minutes of time with the intubation before they desaturate. That's not going to be possible with this woman, just based on the degree of hypoxemic respiratory failure. But you're going to be trying to get that, to pre-oxygenate her as much as possible to get yourself a safety margin. So again, the old way was intubate first. The newer way is, in these patients with complex multi-system failure, is to resuscitate before you intubate. So we're doing all those type of things. And at the same time, we're getting prepared to intubate. But I'm it's the intubation I see as being more 10 to 15 minutes away as opposed to 2 minutes away at this time. So while we're preparing for intubation, you're getting the RT to get all your equipment prepared, you're getting the patient's bed prepared and all that sort of stuff. You're making sure you have 2 good IVs, and you have to tell your nurses what drugs you're going to choose, right? So when you're choosing your drugs for intubation, generally speaking, in a woman like this, unless we're predicting a very difficult anatomic airway, I would use a neuromuscular blocker. It increases your success rate, and it decreases the time to intubation significantly. Now, that's what the proviso is, that you have a reasonable pharmacological knowledge of the neuromuscular blockers, and that you have people, either yourself or people around you, who have a reasonable skill set with them. But I would go with a neuromuscular blocker, and I'd be using rocuronium in her most likely. Okay, and the dose of rocuronium, it's usually a double dose of what the anesthetists do in the OR, because you want to have the effect within 60 seconds, so that you're ready to go and you're not prolonging the intubation phase very long. But most importantly, you know, this woman is confused, but she still is somewhat aware. You don't want to give someone a neuromuscular blocker and put a tube down their throat and put them on a ventilator without them having a sedative. The choice of the sedative is going to be very important here, though, because again, you have significant concerns about the hemodynamics. And most sedatives that we use for intubation will lead to a drop in blood pressure on their own. Propofol, for instance, would likely drop their blood pressure. Even midazolam would likely drop their blood pressure. So the best choice would likely be ketamine. And we would choose ketamine because it's the most hemodynamically neutral of the choices that we have right now. Again, when you're making a decision to intubate somebody who's critically ill, one approach is to just state what your major concerns are going to be with this intubation. And in this patient, again, I'm going to assume that we're not predicting that she's a difficult anatomic intubation. In other words, I'm going to be able to see the cords reasonably well. Sometimes that is a major concern, but there's nothing to suggest that in this woman. So in this case, the major concerns are that she's very hypoxemic, she's acidotic, and she has a borderline hemodynamic situation. So I'm worried that she will become very hypoxemic very quickly if I don't do this quickly and I don't do it well. And she could have a primary hypoxemic arrest during the intubation period. I'm also worried that we could have she could crash hemodynamically during the intubation period. So with that in mind, I'm choosing a rapid sequence intubation technique with a neuromuscular blocker and using ketamine as my sedative agent. And I have a plan B and plan C already in my mind before I intubate this person. I'm expecting some hemodynamic challenges. So whatever dose of Levophed she's on right now, I'm probably going to crank it up a little bit. I'd have some phenylephrine available if necessary, and I'd be monitoring the patient very quickly. So that's sort of the mindset in terms of going on to intubate the patient. So we intubate her. Okay, so the intubation goes reasonably well. We have to give her, say, 200 to 300 mics of phenylephrine, and we have to crank up the Levophed a little bit. But we're able to do this fairly smoothly without a significant desaturation. With the intubation is done on the first attempt in less than 90 seconds. That's sort of the benchmarks that are given now for intubations. So first pass success should be 90% of your intubations. You should be able to intubate within 90 seconds of starting the attempt. There should be no desaturation less than 90%, and your blood pressure shouldn't drop below 90. Those are the parameters that paramedics in the United States are held to in terms of intubating in the field. All right, so she's intubated. Now we're starting mechanical ventilation. Okay, so then we're aware of all the possibility of dropping the blood pressure. We're going to be watching for that and the differential diagnosis here. But the RTs are going to ask you, what mode of ventilation are we going to start in this woman, right? And we talked about how for the purpose of this course, we're going to choose a volume assist controlled ventilation. Remember, on volume assist controlled, the set variable is volume, meaning that the patient will get the 500 cc's or whatever we set every single breath. And then if the set variable is volume, then the dependent variable is going to be pressure. So we'll be looking at the pressure tracing on the ventilator to make sure that when we're delivering that 500 cc's, we're not causing excessive high pressures to begin with. So we're choosing assist control. We're going to choose 6 to 8 mLs per kilogram. We'll go with 8 mLs per kilogram for this woman. Remember, it's not I think she's 170 pounds. But she's only 5'2". So it's really height-based and sex-based, and there are formulas to convert that to predicted body weight. So for her, I would say it's probably going to be around 400 cc's, 360 to 400 cc's. That's what I expect it to be, but I have to do the calculations to know. And then we're going to set the rate at, well, the rate is going to depend on what we think the minute ventilation is going to be. This woman, we don't have a history of her having COPD or bronchospasm, so her risk of developing auto PEEP, I think, would be pretty low. We'll look for it anyway, but it's going to be pretty low. But we're probably going to be setting the rate a little bit higher, like 14 to 18, given her metabolic acidosis at this point in time, and we'll make adjustments to that. We're going to have her on a PEEP of 5 to start off with, and 100% FiO2, right? And, we'll confirm the endotracheal tube position with the end-tidal CO2, and we'll get a chest x-ray. We'll do all that sort of stuff right now. So the ventilator, you're now on the ventilator. You're going to be adjusting the tidal volume and the respiratory rate based on the blood gas pH and your targeted minute ventilation for that. And as far as the oxygen saturation, you're going to have the patient on a pulse oximeter. You started off on 100%. Hopefully, you'll be able to start decreasing that every 5 minutes or so, targeting 92 to 96%. If you're getting, you're not able to decrease that below 60%, 50%, you'll start increasing the PEEP, keeping an eye on the peak pressures right now. Okay, and you'll also be looking at other things on the monitor. So they placed her, let me see, they placed her on assist control at tidal volume of 500. They're claiming that is 6 to 8 mLs per kilogram. I don't think so if we actually did the weight. They put her on an FiO2 of 100% and PEEP of 5. That's perfect. And in addition to the chest x-ray, you need to get a blood gas about 30 minutes afterwards to make adjustments. So 10 minutes later, she's breathing at 21 per minute. Remember, we may have set the rate at 14 or 16, but the patient is able to trigger additional breaths above that on volume assist control. And each of those patient-triggered additional breaths will be full 500 cc tidal volumes. That's one of the, that's a difference between volume assist controlled and SIMV, which, you know, as I said, we don't use much anymore. Her blood pressure has dropped to 80/40. Her MAP is 54, and her heart rate is back up to 123, sinus tachycardia. Her O2 saturation is 98%, which is still a bit concerning considering she's on the FiO2 of 100%, but nevertheless, still has a low CVP, and her central venous saturation is 53%. So the question is, what needs to be done at this time? So I would say we've taken control of her airway right now. It looks like the tube is in the right position, and we're not having any significant difficulties ventilating her. We're still waiting for a blood gas to come and see, but we're not, the peak pressures are okay, the flow tracings are okay. So that's, the ventilation is not our concern. We're still a little bit concerned about oxygenation, but we have a plan in place for that in terms of decreasing FiO2 and going up on the PEEP if we need to over the next little while. The real concerning thing is that she's hypotensive again, she's tachycardic, and she has a low CVP, and again, her central venous saturation is still low at 53%, indicating that her cardiac output is low. So what would we do at this point in time? Again, I would give her another fluid bolus with those parameters. What type of fluid? It's debatable. Colloids versus crystalloids, there's no clear evidence of one versus the other. We tend to go with crystalloids, again, because there's no evidence for superiority with colloids, and there's concerns of increased side effects, and it's much more expensive. In terms of crystalloids, the debate is whether you're going to use a chloride-rich solution like normal saline, or you're going to use a balanced solution like normal sol or Ringer's lactate. So again, there's ongoing studies to see if there's concerns that normal saline may cause, it certainly causes an increase in hyperchloremic metabolic acidosis. The question is whether that's detrimental to patients, with the kidneys being the organ that's most concerning about that. There is some preliminary data suggesting that balanced crystalloids are better, but we have to wait for more definitive studies. I generally prefer the balanced solution, so Ringer's for me, but you could state that there's equipoise in this question. Okay, I'm just checking the chat box and see if anything's coming up. No. All right. So I think what we'll do at this point in time is just take a 5-minute break, because I've been talking nonstop now for 50 minutes. So just take a 5-minute break to stretch, and then we'll wrap it up in about 20 minutes after that, 25 minutes. And at this point, the patient is going to go through a series of brief complications, and the question is how to respond to each one of those things. Could you please re-explain rapid sequence intubation? Yeah, okay. Could you please explain again why we prefer Ringers? Yep, over normal saline. How about if we take the break first? So that will give you something to look forward to in 5 minutes. All right, so right now it is 1 minute to 1. So at 5 minutes after 1, we'll start back up and I'll answer those 2 questions then. No, I'm taking a break now. Let me see. The first thing I'll answer is the colloids versus crystalloids versus balanced versus non-balanced. So again, no evidence for colloids over crystalloids. Crystalloids are cheaper. You don't have to worry about some of the negative side effects of colloids for the most part. For the crystalloids, the question is, why do we prefer ringers? It should be better phrased, why do I prefer ringers? Because there is equipoise and there are people who prefer normal saline. But I'll tell you that normal saline is a misnomer. It should really be called abnormal saline. There's nothing normal or physiologic about it. It's got a sodium concentration of about 154, so it's hypertonic. But more importantly, the chloride is also 154. So that's much higher than the normal serum chloride of patients. If you give a large volume of normal saline, so it doesn't really matter if you're only giving 1 to 2 liters of something, but some of these patients in the intensive care unit end up getting a significant amount of crystalloid when you're looking at over 3, 4, 5 day period. And once you start getting up into higher amounts of crystalloid of normal saline, the patient's serum chloride level is going to keep increasing. So it's going to go from 105 to 110 to 115, maybe up to 120. That will result in a hyperchloremic metabolic acidosis. So there's several reasons why that may not be desirable. Number one, it sort of complicates your assessment of acid-base balance later on, because you can't tell if the acidosis is not resolving sometimes, or not resolving or worsening. Sometimes you're not certain whether it's just the normal saline that you're giving that's causing the additional hyperchloremic acidosis, or it's an indication that the patient's own physiology is not resolving or improving as fast as you'd like itself. So that sort of just complicates the assessment a little bit. But then the real question is a hyperchloremic acidosis, is that high chloride load itself detrimental to patients? And there is some evidence that it can cause renal vasoconstriction, and it can cause an acute kidney injury itself. That evidence is not bulletproof or 100% certain, but there is at least signals in preliminary studies that suggest that that may be an issue. And there are randomized controlled trials that are ongoing to sort of better clarify the picture. So that's why I prefer a balanced solution as opposed to chloride-rich normal saline. Now, the situation where I'm not comfortable with Ringer's lactate, so the problem with Ringer's lactate, it's not perfect either. It has a sodium level of 132. If you're worried about patients with cerebral edema, brain edema, then that can drop your serum sodium level down to close to 132, and that can be problematic. People get worried about the 4 milliequivalents of potassium in Ringer's lactate. I'm not concerned about that myself. The potassium load is not high enough to make a big difference if you're worried about someone getting hyperkalemia. And I'm not worried about the lactate in the Ringer's lactate. It gets metabolized almost immediately to bicarb, and it doesn't affect your serum lactate measurements in any sort of clinically relevant way. So that's there is a normosol, which is more balanced. In other words, has a sodium level of 140 something. I forget exactly what it is. So you don't get the hyponatremia that you get with Ringer's lactate. It's just not as immediately available within the MUHC. It costs a little bit more. Does that answer the question of, in a patient with a risk of ischemia, that we want to monitor lactate? Okay, so I answered that question. Does that answer anyone's questions about colloids versus crystalloid? It's a big debate that you could have a 1 to 2 hour talk just on that. Yeah, okay, good. So the next question what brought up is to explain rapid sequence intubation. So rapid sequence intubation was sort of developed by anesthetists and patterned on what they call a rapid sequence induction. So sort of the classic induction of anesthesia in the OR is a sort of a gradual, slow process. So you gradually bring somebody under. If you had somebody who is a full stomach, you would induce them much more quickly and intubate them in order to decrease the risk of vomiting and aspiration. So in emergency situations, generally you have to assume, for the most part, that patients have full stomachs, and that's one of the reasons why rapid sequence intubation is used in that sort of situation. But there are other reasons as well. So a rapid sequence intubation can be defined as the near simultaneously giving of a sedative agent followed rapidly by a paralytic agent, a neuromuscular blocker, to induce unconsciousness and paralysis within 60 seconds or 90 seconds at the most to facilitate endotracheal intubation. Okay, so I'll unpack all of those things. So what we're doing here is, one, we're making a determination that the patient is not expected to have significant. Somebody's mic is open. If you can just mute, everyone can just mute. Where was I? Oh yeah. So what we're is predicated on the number one, you're not predicting a difficult intubation from a laryngoscopic point of view. You know, this is not somebody with a midfacial smash or some sort of really strange anatomic difficulty itself. So it's predicated on that you're predicting you're going to be able to intubate the patient. If you give a neuromuscular blocker, your chance of intubating the patient actually goes up significantly, from about 90 to 92% up to about 99.5% in medical patients and about 99% in trauma patients. And that's based on huge registries of 20,000 patients. And it was R1 to R3 in emergency medicine residents doing the majority of the intubation. So it's not based on somebody with, you know, a really high levels of skill. So why does that, if you paralyze somebody, you take away all the muscle tone, it does become significantly easier to get the tube in a rapid fashion. And again, somebody who is crashing because they're critically ill or has a risk of vomiting because they have a full stomach, there's a significant advantage to doing that. You need to, for the most part, give some sort of sedative agent so the patient is unaware of this. And the sedative agent actually does help to facilitate intubation a little bit as well. When you're at the cutting edge of the onset of neuromuscular blockers like this, the sedative agent does make a difference. So you usually, rapid sequence means that you usually give a dose of a sedative agent, and your choices there would be ketamine, midazolam, propofol is the most common one that we use, but there are others. And what you're doing with that is you're just you're not titrating in the dose to a level of unconsciousness. You're choosing a dose that you think is going to work and without causing too much hypotension. So it requires a bit of experience with the agents. You're giving that dose. So let's say you're giving 1 milligram per kilogram of propofol. So 60, 70 milligrams of propofol. You have that pushed in by your nurse, and immediately after that's pushed in, you're going to be giving the rocuronium at 1.2 milligrams per kilogram. At that, you've already been pre-oxygenating the patient. You've already prepared everything else that's going on. So you're ready to go, but you're waiting 60 seconds. You're monitoring the patient's saturation during this time period. You're trying not to bag during this time period. And you're waiting 60 seconds for the sedative agent and the neuromuscular blocker to take effect. And then you're passing the tube with idealized or optimized conditions. Does that explain it to everyone? If anyone has any more questions about rapid sequence? Okay, so we will move on. Where were we? All right, so we just put the patient on a ventilator, and recognized that we weren't having much difficulty ventilating. Oxygenation was still a concern, but we now have a saturation of 98%, so it's not an immediate concern any further. We're hoping to gradually decrease the amount of FiO2 that we're giving the patient, but we're still concerned about the hemodynamics. And again, the patient is hypotensive with a MAP of 54, tachycardic at 123, has a low CVP and a low central venous saturation. So again, the question is, what type of shock is this patient in, right? And is there any other things that we could do to better clarify the type of shock the patient is in? I would say that this patient has both a distributive and a cardiogenic component to it. What they do here is that they place a Swan-Ganz catheter. They say a cardiac output monitoring device is placed. There's multiple different devices that we can use, but this one turns out to be the gold standard, which is a Swan-Ganz catheter. We have esophageal Dopplers, and we have some non-invasive types of, or semi-invasive types of monitoring cardiac output. But if you wanted to summarize, at least for the Royal Vic Emergency Department site, if you wanted to summarize the resuscitation approach, you could say that it is a flow-directed dry ICU that still believes in Swan-Ganz catheter, because the Swan-Ganz catheter is becoming less and less popular globally. And if you go to the Montreal General ICU, you will rarely see a Swan-Ganz catheter, maybe once a year or something like that. And at the Jewish, it's sort of intermittent between the two. And that has something to do a little bit with the resuscitation philosophies, but more importantly, with the patient populations. So at the Royal Vic Hospital, we tend to have a lot more severe cardiac cases, particularly right heart dysfunction with pulmonary hypertension. And that's the patient group where Swan-Ganses are the most useful. And at the Montreal General Trauma ICU, mostly young trauma patients, Swan-Ganses are less useful in that patient population itself. But what does that mean? Flow-directed dry ICU. So what that means is that some sort of assessment of patient's blood flow or cardiac output, if you want to call it that, is the most important thing in determining how you're going to resuscitate them hemodynamically. What we're saying is flow or perfusion is much more important than blood pressure. Blood pressure is a late finding, and it's not a great resuscitation endpoint for reasons I'll get into in a minute. So what really matters to the patient is whether their mitochondria in their peripheral organs are getting enough perfusion and oxygen. That's what we really care about. The blood pressure, yes, is important for perfusion across vascular beds, but it's not as important as perfusion. Therefore, having some measurement of perfusion or some sort of assessment of perfusion should always be part of your assessment. And you can go from clinical to semi-invasive to invasive ways of looking for hypoperfusion or adequate perfusion. So in terms of your clinical exam, you have the sort of the three big windows into the perfusion status of the patient clinically. The first thing, the window is the brain. So if the patient is awake and alert and has a normal mental status, then you know the brain is getting adequately perfused, right? And if the brain is getting adequately perfused, probably the rest of the organs are as well. If they have altered mental status, there may be other reasons for the altered mental status, but still you have to question whether the brain is being adequately perfused, whether the cardiac output is adequate in that situation. The other two windows you have clinically into perfusion status are urine output. So generally you have to put a Foley in for that, and it's going to take a while for you to actually be able to follow the urine output. But urine output is an indication of renal perfusion. Again, if the urine output is low, there may be other reasons besides inadequate perfusion, but it certainly puts into question about the perfusion. And then the last thing, and that's a thing that's often forgotten or underappreciated at the bedside, is just an examination of the skin and the peripheries. So if the peripheries are warm and they have good capillary fill, then at least you know that those are being adequately perfused. And there was a paper in the last year and a half in JAMA that compared capillary fill to lactate clearance as a resuscitation endpoint in septic shock, indicating that they're equivalent, meaning that it's just as useful to keep checking your fingers, the patient's fingers, and looking for a cap fill less than 3 seconds with warm extremities as it is to do a lactate level every 2 hours and look for decreasing lactate itself. I would do both, but I'm just pointing out that you start off with looking at the brain, looking at the kidneys for perfusion, and the skin extremities for warmth and capillary fill as evidence of perfusion. Now, if that was enough, we wouldn't need anything fancier than that, but it's not always enough. And often you do the exam and you're not certain. As I already pointed out, there might be other reasons why the mental status is off, or the urine output is low, or why the peripheral circulation is a little bit decreased. So in terms of lab tests, it's really your arterial blood gas or a venous blood gas. And you're looking for metabolic acidosis and primarily a lactic acidosis, right? You may also look for evidence of other organ dysfunction at that time, such as an acute kidney injury. When then the next steps beyond that, you're starting to get into the invasive or semi-invasive testing. You can put in a central venous line and measure the central venous saturation. We talked about that already. After that, your options are some machine that is going to get you a direct number that correlates with cardiac output. And your options there would be, before you do that, bedside ultrasound. So you can take your ultrasound to the patient at the bedside. You can look at the right ventricle and left ventricle. You get an assessment of whether it's hypercontractile or hypocontractile. And you can look for volume status by looking at the IVC. It'll give you some idea. While you're doing that, you're going to be looking for pericardial tamponade and other things as well. But at least it's a way of determining, giving you some idea about what the cardiac contractility is and what the volume status of the patient is. In addition to that, we have something called an esophageal Doppler. So it's like a small NG tube that you put in halfway down around T8 to T10, sorry. And you focus on the aorta, and it will be able to measure the flow velocity time signal in the aorta, and it can convert that to a cardiac output. There are arterial pulse contour analysis techniques where you take the arterial line tracing, and everyone seems to know that if the arterial line tracing is swinging with inspiration versus expiration, that suggests that the patient has a lower cardiac output and they may be volume responsive. And these machines just mathematically analyze the arterial pulse waveform and convert that to a cardiac output. And then beyond that, you have the Swan-Ganz catheter, which allows you to measure a cardiac output indirectly through a thermodilution technique. So let's say that we have in this patient, or we do actually, we put in the cardiac output monitoring device. Let's say it's a Swan-Ganz catheter, so it's the gold standard here. And we have, in addition to knowing that the blood pressure is low and the CVP is low, we now have a cardiac index of 1.7. Now, a normal cardiac index is 2.2 to 2.6, right? And anything below 2, we start getting worried about. And we know that his central venous saturation is 57%. So we have good evidence that this patient has a decreased cardiac output, right? So the reason why the blood pressure is low is not just because he's got a distributive shock, a septic shock with dilated blood vessels. But this patient also has a significant problem with cardiac output and with perfusion to end organs. So again, getting back to the premise that perfusion is more important than blood pressure, we have to address the patient's hyperperfusion at this point in time. So when you have a patient with a low cardiac output or hyperperfusion, your first question should always be, could this patient be volume responsive? Right? Because volume is the quickest and easiest and probably, for the most part, the least detrimental therapy that you can give at this point in time. So with a CVP of 2, it's most likely that this patient is volume responsive. Not necessarily true, but most likely this patient is still volume responsive. So I would give another 500 cc's of Ringer's lactate. I would give that Ringer's lactate as quickly as possible. You'd want it in within 5 to 10 to 15 minutes at the most. And you're going to be looking to see if there is a positive response. So if you don't have a Swan gas catheter, you'd like to see the heart rate go down and the blood pressure go up, but we actually are able to measure cardiac output. So if I give a 500 cc bolus here and I get the CVP going from 2 to 8, so a significant rise in the CVP, and I see no increase in the cardiac index, then this patient is on the flat portion of the Starling curve, and more fluid is not likely going to be beneficial. You'll have to move on to something else. But most likely, if I give enough fluid to increase the CVP by 4 or 5, the cardiac index will come up. So let's say I give 500 cc's of Ringer's lactate, the CVP goes from 2 to 8, and the cardiac index goes from 1.7 to 2.0. So that indicates to me that he's had a positive response to that volume challenge. That may not be enough for me. I may want to have the cardiac output even higher. So I might give an additional fluid bolus at that, another 500 cc's. And again, if the CVP goes from 8 to 12 and the index goes from 2 to 2.4, I've done something good. On the other hand, if it goes from 8 to 12 and the cardiac index stays the same, then the patient is no longer volume responsive and I should move on to something else. So what is that something else? It's going to be an inotrope. So it's going to be something that causes the heart to contract better. And your options there are a beta agonists, with dobutamine and epinephrine being your 2 major choices. There are others, but we'll go with that. We can sometimes use milrinone, although I'd be careful using milrinone in this situation because it causes vasodilatation, so it's going to worsen that part of the problem right now. Remember, we're dealing just with the cardiogenic shock right now. There's still a distributive shock to deal with as well. So either dobutamine or epinephrine at this point in time. And how do you do it? Well, let's say we're going to use dobutamine. We'd start off at 2.5 mics per kilo per minute. Don't remember, the doses are not important for you to remember. The point is you start off at a low dose, and then you check again in 10 to 15 minutes. If it's having a positive effect, the cardiac output should be going up, the heart rate should be going down, the blood pressure should be going up. You keep titrating it upwards until you get the effects that you want. In other words, you feel that you've resuscitated the patient as much as you want, whatever your targets are, or you're limited by some sort of side effect. And the side effects for dobutamine are primarily tachycardia and hypotension. Okay. If dobutamine doesn't work, then the next agent is usually epinephrine, and it's the same sort of thing. It's a titrated approach. So it's not like antibiotics where we order 4.5 grams of tazocin every 6 hours. For inotropes and vasopressors, you're always titrating it up and down, looking for a particular positive response. So you have a target in mind, or you're looking for a negative side effect of those drugs that's telling you that you're going to have to stop and try something else. So we're going to, we gave the fluid, he's no longer volume responsive, we're starting the inotrope, we now have the cardiac index up to, let's say it's 2.5, the mixed venous is improving, so we have good perfusion now, and now we're still worried about the blood pressure to some degree. So with the good cardiac output, the MAP is still about 55, okay? And we're choosing a MAP target of 65. That's what's normally targeted, but to be honest, we really don't know what the optimal MAP is in for a large population of patients. Many people try to study it. It's very difficult to get a reasonable answer on it. But for the most part, we think that most organs, autoregulation is sufficiently intact that once you get the MAP up to 65, you're probably perfusing okay. So in terms of, we've dealt with the pump problem right now in terms of the cardiac output with fluids and dobutamine. Now we're focusing on the arterial tone problem. In other words, the vasoplegia that the patient has because of the cytokines that were released because of the sepsis. So for that, we're going to use a vasopressor agent. So something that's going to cause squeeze of the peripheral arteries and arterioles itself. And our go-to drug is Levophed in this situation. Levophed has a significant amount of alpha effect. It also has a little beta effect. And the reason why we choose Levophed, you can say, why not just a pure vasopressor like phenylephrine? The reason why we choose Levophed is that we don't always have a cardiac output monitor in place. And if you're in a situation where you think that this patient has just pure distributive shock, in other words, the cardiac output is not limited, if you put them on a pure vasopressor and increase systemic vascular resistance, and you're wrong about the status of the heart, you're actually going to increase afterload there and decrease perfusion. The fact that Levophed has a little bit of beta activity is a safety margin against that, if you can understand that. So that's why Levophed tends to be our first-line vasopressor. If you're not getting a good response, so what you do with Levophed, you start off at about 2 to 4 mics per minute, and then you rapidly titrate it up until you get your MAP where you want it, at 65 or 70, whatever it is. If you have a patient who is very refractory to Levophed, the next steps would be to add vasopressin, which works by it's a non-catecholamine vasopressor, so it works by a different mechanism. It doesn't stimulate the alpha receptors. And if that doesn't work, the next step beyond that is steroids. So steroids work synergistically with the vasopressors to address the vasoplegia. So that's the approach to the hemodynamics of somebody who's in septic shock, but septic shock with a hypovolemic component and with a cardiogenic component, as well as the vasoplegic distributive component. So hopefully that's clear to everybody. Again, just step back. One way of looking at this is that the blood pressure is equal to cardiac output times SVR. And so you can look to see if it's a pump problem, meaning the cardiac output is low. If it's a pump problem, it's because you look to see if it's hypovolemic shock, cardiogenic shock, or obstructive shock. Once you've taken care of that, then what's left is the distributive component. For the distributive component, it's a vasopressor, either Levophed or vasopressin. Okay, so we're now, we've intubated the patient. Initially we stabilized from a respiratory standpoint, and now we've resuscitated him hemodynamically. We're now going back to the ventilator to do a little bit more fine tuning. So they have are these flow and pressure waves satisfactory? So you see a pressure versus time curve. It's not quite what it really looks like in real life, but anyway, I'll accept that. What they're trying to indicate there is that you don't have a very excessively high or a low pressure at this point in time, so it doesn't look like there's any problems from that point of view. And if you look at the flow versus time graph, you'll see that flow all on exhalation, flow always comes back to 0 before the next breath, so there's no auto peak. Those are the 2 bits of key information you want from those graphs. So moving onwards, what is the next step for the hemodynamic management? I thought we dealt with that. So it says continue IV fluids and increase vasopressor dose to try to maintain the MAP above 65. So let's say we've accomplished that aspect. We've given the hydrocortisone. That was what the answer is to what is the next step there. And we're just going to continue on because we've already dealt with the hemodynamics. So now we're at assessment and findings 5 hours later. So this has been an ongoing battle all day with this patient. So the patient is receiving mechanical ventilation with a tidal volume of 500. The respiratory rate is 14. The FiO2 is now down to 50%, the PEEP of 5, and you're now down to norepinephrine to Levophed at just 2 mics per minute. So this is signs that the patient has been improving right now. In other words, it looks like you have appropriate antibiotics, it looks like you have source control, and it looks like you're meeting your resuscitation endpoint so far in terms of oxygenation, ventilation, and hemodynamics. So things look good. But then you suddenly get called for because the high pressure alarms on the ventilator are alarming. And so the question is, what do you look for? Well, the first thing that you can do, as we talked about yesterday, is you can do a 1 second end inspiratory hold. So what that means is just at the end of expiration, you push a button on the ventilator. It prevents any further gas from going into the patient. So no flow into the patient, but on the other hand, it also prevents the patient from exhaling. So you will then get a drop in the pressure from the peak pressure down to the plateau pressure, and the magnitude of that drop is going to be proportional to the resistance of the airway system, right? And the rest of the pressure left behind is going to be proportional to the elastance or the compliance of the system. So it helps you determine whether this is a resistance problem or a compliance problem. And there's different, it just allows you, there's different things that cause each one of them. So this one, you have a peak pressure of 48 and the plateau pressure is 25, meaning there's a big drop, meaning that there's a big problem with airway resistance. That's the problem right now. Now, it could be that the patient, it could be something intrinsic to the patient or something intrinsic to the tube itself. So the first thing usually is you check the tube, you make sure it's in the right position, you make sure it's not kinked, you make sure it's not a big plug inside the tube itself. And you do that by, one, separating the patient from the ventilator, bagging the patient, but passing a suction cannula down the endotracheal tube and making sure the tube is patent itself, right? If the patient is obviously biting the tube, and that can happen sometimes when they're sort of delirious and agitated, then you have to increase the sedation or maybe even give a neuromuscular blocker to get them to stop biting the tube itself. If it's not the tube, then it's the patient itself. And again, we don't have a lot of information about the patient, but maybe she is a severe asthmatic or COPDer, and for whatever reason, we've just induced acute bronchospasm right now, in which case the treatment would be bronchodilators. Now, on the other hand, if the plateau pressure was very high, let's say the peak pressure is 48 and the plateau is 40, that would indicate it's more of a compliance problem. And the thing that you would worry about most there would be a pneumothorax. So you'd be looking for signs of pneumothorax, and you might even consider putting in chest tubes at that point in time. Other causes of a sudden drop in airway compliance would be maybe the endotracheal tube moved down, so you now have a right main stem bronchus intubation, so you're only ventilating one lung as opposed to two lungs, or you have a collapse of one lung for whatever reason. You have a sudden massive hemothorax would be the things that you'd be looking for. So that's how you'd be troubleshooting the high pressure alarms. Then you're called later, I guess, because the patient is uncomfortable and laboring inspiratory efforts. And this time you have this new ventilator graphics. So you can turn the page. What you see here is that the pressure versus time waveform looks normal. In other words, it's not a high pressure or low pressure. But what you have is on your flow versus time tracing, you're seeing on exhalation does not come back to zero. So this patient is air trapping. So again, this would suggest that this woman does have some sort of reactive airway disease in order for this to occur right now. You measure the auto PEEP. In order to measure auto PEEP, it's exactly the same idea as measuring the plateau pressure, except this time, instead of at the end of inspiration, you're measuring at the end of expiration. So again, you have to time it, but just as the end of the patient's expiration phase is about to end, you press a button on the ventilator. It prevents any gas flow from getting out of the patient or any gas flow getting into the patient. So you basically trap the gas in the lungs, and you measure the pressure that's there. So that would be the end expiratory pressure. So you measure the auto PEEP, it's 15 centimeters. And now we're into a discussion of what to do about auto PEEP, right? And so we had the discussion yesterday. Basically, what you need to do is allow as much time as possible for the patient to exhale while you're waiting for the bronchodilators and the treatment of the underlying process to have effect. And you can do that by, one, getting less air into the lungs to begin with. So if you have a tidal volume of 500 cc's, if you put in 400 or 300 cc's, then you have less air to get out. That helps. You can put in the 500 cc's in faster. So you can, if you're putting in 1.5 seconds, you can increase the flow, double the flow, and put it in 0.75 seconds. That gives you an extra 0.75 seconds for exhalation. Or you can decrease the respiratory rate. As you decrease the respiratory rate, you're increasing the amount of exhalation time, right? When you're looking at over a 1 minute period. So those are the things that you're doing, and you may, if you have a bad problem with auto PEEP, accept permissive hypercapnia for a period of time. Again, there's no reason to think that this woman has increased intracranial pressure at this point in time, and that's the only major contraindication to letting the CO2 go up to 60, 70, 80 for a period of time while you're waiting for the bronchospasm to release. Okay, so the patient, so what they did here is 30 minutes later, they dropped the tidal volume to 300. The respiratory rate is still at 14. And you get a blood gas back that shows just that. The pH is 7.27, the PCO2 is 65. So they're just accepting the hypercapnia, because the alternative to try to bring that down to normal would likely be more auto PEEP, which would lead to decreased cardiac venous return, decreased cardiac output, and be more detrimental. Why do they want? They go into something about the plateau pressure again. Basically, they're just getting you to assess the patient one more time. Let's quickly go over to the chest x-ray. And what you're seeing now is, unfortunately, this woman has developed ARDS. We know that this is not a cardiogenic pulmonary edema at this point in time, because we have a cardiac output that is reasonable. We can actually measure the wedge pressure if we need to at this point in time, but with the CVP being that low, it's unlikely the wedge is high. So the definition of ARDS is a non-hydrostatic pulmonary edema, meaning that the wedge pressure has to be less than 18. So you have a leaky capillary syndrome as opposed to a dysfunctional left ventricle and with a back pressure on that basis. So it's a leaky capillary syndrome. You see diffuse infiltrates on the chest x-ray, basically a whiteout. And the patient has a significant need for oxygen. So meets the criteria for ARDS. So then the question is, how are we going to treat somebody with ARDS? And basically, we're going to be more careful. We should always be careful, but more careful in trying to diminish ventilator-induced lung injury. And again, the 4 types of lung injury that we're concerned about with a ventilator are volute trauma, barotrauma, what's called atelectatrauma, which I won't get into that much, and oxygen toxicity. So what we want to have is a FiO2, hopefully 60% or less. If it gets, the higher it goes above that, the more likely that oxygen itself will injure the lungs if kept at that level for a long period of time. And you do that by increasing the PEEP. Atelected trauma is you have this collection of alveoli that collapse and open and collapse and open with every breath. And that opening and closing is again felt to be detrimental to the lungs. It causes local lung inflammation and then worsening. And again, you treat that by increasing the PEEP itself. In terms of barotrauma, the problem with increasing PEEP is it's going to increase your peak pressures as well and your plateau pressures. So you want to keep the plateau pressure less than 30. And what, years and years ago with ARDS, it was not uncommon to have, it would be great for residents who needed practice with chest tubes, because you would have patients with 4 chest tubes on one side and 3 on the other, because we used to use much higher pressures at that time, and we'd cause a lot of barotrauma and pneumothoraces. So now you rarely see a patient with ARDS requiring a chest tube because of that change in the management. And then the final thing is volume trauma. And again, it's the baby lung concept. The fact is that so much of that lung, if you look at the chest, the chest X-ray, the whiteout, so much of that means that the lung is collapsed. And if you try to put in a full normal person tidal volume into somebody with this amount of lung collapse, what you're going to end up doing is just overstretching the good parts of the lungs, and that's going to cause harm. So if I was going to say what the major difference in the philosophy of mechanical ventilation and ARDS over the last 20 years is that we no longer, back in the 1990s, for instance, we used to give priority to trying to normalize the blood gas and make the patient as comfortable as possible. And those both sound like good things to do, make the patient as comfortable as possible, and 2, aim for a normal PO2, normal pH, normal CO2. But in fact, the ARDS study showed that approach was actually causing increased mortality. And so that's why by about 8 to 9%. So that's why we choose this mode of ventilation. We're not going for normal blood gas. We'll accept permissive hypercapnia at times. And we're going on smaller tidal volumes. And the reason I mentioned patient comfort, these smaller tidal volumes in somebody who has air hunger is often uncomfortable for them. And it requires more sedation than usual for them. But if we try to make them as comfortable as possible on the ventilator, it's often at the cost of eventually injuring the lungs. At the end, I think we're starting to win here at the end. We have vital signs that are pretty good. So a MAP of 72, blood pressure 110 systolic, heart rate is now only 98. You're at 14 breaths per minute. And you have if anything, the saturation is a bit too high. That's another change in the last 2 or 3 years. It seems that targeting saturations greater than 96% for a long time in the ICU again causes increased problems, probably because of oxygen toxicity, free radicals. So we target 92 to 96%, and if we had a saturation of 99%, we'd be cutting down the FiO2 now. The central venous saturation is good at 77%. The patient is afebrile, and there's nothing else. Oh, yeah, this case goes on and on. All right, this is going to be the last thing because we have like 10 minutes left. Thank you for your attention so far. So now we're going into atrial fibrillation. The patient is getting better again. So this is a really irritating patient. Every time they seem to be getting better, another complication occurs. But this is a patient who's now in atrial fibrillation. And it's atrial fibrillation with a low blood pressure, 70/35. That would indicate to me that this patient does not have a normal heart. They don't mention what the heart is to begin with, but if you have a normal left ventricular ejection fraction of 60, 70%, you should be able to tolerate atrial fibrillation even at 180 beats per minute without dropping your pressure. It's usually patients that have significant valvular disease or a significant cardiomyopathy that cannot tolerate a rapid atrial fibrillation. Meaning that for the most patients, atrial fibrillation is not an emergency. It's something that you have some time to sort of figure out what you're going to do about it. But the one situation where it is an emergency is when it's associated with hypotension. So the treatment for that is shocking. So you cardiovert this patient. And this patient would be relatively easy to cardiovert. They're already sedated, they're already intubated, so you don't have to worry about the airway, you don't have to worry about sedation. You just have to bring the defibrillator to the bedside, put on the pads, and then make sure everyone is clear, and then shock the patient. They talk about what could be causing the atrial fibrillation. And so you can think about the top 3 or 4 or 5 things of causing atrial fibrillation in an ICU. The things you'd look out first would be electrolyte abnormality, so hypokalemia, hypomagnesemia, and you would correct those as possible. Hypoxia and acidosis can cause atrial fibrillation. An acute myocardial ischemic event can do it, pulmonary emboli. So those are the things that you think about for the most part. Now, they're saying, what if this patient had chronic atrial fibrillation and the blood pressure wasn't a problem? In that situation, atrial fibrillation should be considered just like sinus tachycardia. In other words, the real treatment should be looking for the underlying cause and trying to revert the underlying cause. If you've done all that, then you can use an agent to decrease the heart rate. They're talking about a beta blocker here, but I would not start a beta blocker on somebody who's on Levophed. So, and I wouldn't use a calcium channel blocker either. I would be using digoxin to control the rate in this patient itself. The final thing, just for the interest of time, we'll talk about how the patient suddenly goes into a PEA arrest. And the question is, what are you going to do for a PEA arrest on a patient like this? Again, the first thing I would do is go for the airway, make sure the tube is in the right position. I would disconnect the patient from the ventilator and bag them, make sure the tube is patent. So you start with the airway itself. In terms of its PEA, so if this is a narrow complex rhythm, then it's not likely going to be a primary cardiac issue at this point in time. So you're going through your differential diagnosis of shock, giving volume if there's a hypovolemic point of view, and increasing the inotropes and vasopressors. You can go through the H's and the T's, but oh, no, now I see. I think what happened is they gave the patient some, sorry, I forgot about this aspect. So the patient went into atrial fibrillation. Then they start amiodarone. And then the patient goes into a 2nd degree heart block, probably related to the amiodarone, and is bradycardic because of that. So that's the reason why the patient's in PEA. In that case, the treatment is going to be a transcutaneous spacer. So if you still have the pads in place from your atrial fibrillation cardioversion, you should at this point in time, you just go to pacer mode on the defibrillator pacer. You turn up the voltage to the maximum, turn up the rate to about 80, and try to get capture. If you're not getting capture, then it's because the pads are not in the right place, or they're not sealed against the skin well enough. So you try to change the pads or change the position. If that doesn't work, it's a transvenous pacer. So that's the end. Hopefully that's the end of it. Yep, that's the end of it. So we got 6 minutes to go. That was a marathon. But I hope that was useful for you. So again, you can go through this case, try to use your mind as your simulator, and try to put yourself on the floor, what you would be doing with patients like this, and go through these scenarios yourself at times. It will help you when you get into the real life situation. So that's it, I think. So I hope the course was useful for you this year. I've gone through a few of the lectures, and I think it's not too bad. I think, number one, the guy goes a bit quick in terms of the in terms of the speaking of on the lectures itself, but that gives you the chance to stop and go back. But I think it's interactive enough that it's getting the points across to you. But I would still suggest that you take full advantage of reviewing these lectures before you go to your ICU rotations and asking questions as much as you can. All right, so everybody, thank you and have a good year. We'll see you eventually when you come to the ICU. Oh, just to clarify something regarding ventilation modes, is volume assist control the same as pressure regulated volume control? If no, oh no. Okay, I'll try to summarize it very quickly. So the answer is no, it's not. So volume assist control is it's a volume targeted mode of ventilation. Volume cycled, meaning that the machine will deliver 500 cc's with a constant flow rate to go with each single breath. So the patient will get 500 cc's, 500 cc's, 500 cc's, 500 cc's. Okay. Now, if you go to pressure control ventilation, it's what the set variable is pressure, meaning that volume is the dependent variable. So it's exactly the opposite of those two. And volume assist control, the set variable is volume, meaning that pressure is going to be the dependent variable. Pressure will vary from breath to breath, but volume will be the same. In pressure control ventilation or pressure support ventilation, pressure will be maintained the same and volumes will differ. So if let's say you have a patient who's on pressure assist control ventilation, you set the pressure control at 15 and the patient has volumes of 400 cc's. And that's what you want. You want 400 cc's and the rate is good as well. It's about 18. So you're happy with the ventilator setup. And then for whatever reason, the patient worsens. They go into pulmonary edema, they go bronchospastic, they get a mucus plug, whatever it is, the patient's internal mechanics worsen. And the volume drops down to 200 cc's. So you're called to the bedside and you want 400 cc's. So what you're going to do in that situation is increase the pressure control from 15 to 20. So you go up from 15 to 20 and you look for a few minutes and the volumes are back to 400 cc's. So you're happy. You give some Lasix or some bronchodilators to treat the underlying process and you come back an hour later and now the volumes are now at 600 cc's. So what are you going to do? You're going to decrease the volume, the pressure back down to by 5, whatever we were before, to 15 again. So what we're doing then is we always have a secondary target in our mind when we're on a pressure targeted mode of ventilation. It's always we're looking to see what the set pressure is enough to deliver the volumes that we want. So pressure regulated volume control basically does that. You can think of it as taking a mini RT and putting it into an algorithm into the software of the ventilator itself. So what that does is it's still the individual pressure targeted modes of ventilation. But there'll be an algorithm in the computer that if the tidal volume starts dropping over several breaths, it will start automatically ramping up the pressure. And if the tidal volume starts going up, it will automatically start dropping the tidal volume. So it's like sort of an autopilot for a pressure targeted mode of ventilation. I hope that answered the question. It's one of those things I've had 30-minute debates with some intensivists, and it's a difficult concept to see, but for the purposes of this course, you do not have to worry about pressure regulated volume control. The other thing about that is that's a manufacturer's term. That happens to be some particular manufacturer that uses that term. Okay, if there's no other questions, we'll call it a day. Great. Okay. Take care, everyone.